behalf of the uh, current TB, Dr. Shweta, Dr. Yadav, and their team, and the past TB, Dr. Banavli, myself, and our team. This is, indeed a great pleasure to welcome all of you for Best of SIOP. So I thank ECO who have provided this platform for us to conduct this 2.5 hour meeting. Just to set the background, that we are always excited about SIOP. This is the most important meeting that is annually organized for all the pediatric oncology, new developments that happen around the world, around the globe. But you all are aware that, it's not always easy, not always possible to leave your work, families, and attend this meeting, which can sometimes be really far from where we are located in this part of the world. And it used to be an annual event to have Best of SIOP to bring all the knowledge back to India. Somehow down the years, that tradition kind of went away, and a lot of people were actually attending SIOP. But we realized that as the community is growing tremendously, we all are not going to get the opportunity. There will be many people who will attend, but many of us would not be able to attend and learn from the big stalwarts. So we thought of getting the science back home, and we wrote to SIOP, and I'm really, really thankful that, our request was very well appreciated, and they agreed for us to host the Best of SIOP in India. So we said that, we don't have the wherewithal to conduct a big physical meeting, and if we could do an online meeting. And here we are for the first Best of SIOP. I should say Best of SIOP 2.0, because we have restarted this. And I'm sure Shweta, Dr. Yadav, and their team is going to take it forward for every year from the years to come. So welcome all of you once again. And we have a very interesting line of speakers. All these people actually physically went and attended the SIOP meeting. So right from the horse's mouth, we are going to listen to what all they liked or what all they felt is something that we all should know about SIOP that was organized in Amsterdam. I'm very much hopeful that somebody from SIOP will join us too, and briefly, just give their regards and wishes to all of us here. And we'll kind of interrupt the meeting for a couple of minutes when somebody joins from the main SIOP. So to begin the sessions, Shweta and I would like to welcome all our star speakers. And the first speaker is Dr. Venkat. And you all know Venkat. He is from Adyar Institute. He doesn't need an introduction. He's a master of a lot of subjects in pediatric oncology. And a thing which is close to his heart is childhood cancer registry. So Venkat, over to you to start the first session for this evening's Best of SIOP.
Thank you, Manas. I'll just share my screen. Is it visible?
Yes.
Thank you. Thank you for the opportunity, PHIOP and SIOP, and I'm the opening batsman. I'm sorry, I thought initially I had to present my work. If I had known, I would have chosen some other topic. So I'm going to talk to you about the childhood cancer registry, the first in India, which was established in Chennai in 2022, and its importance. These are quite interesting numbers, and you would be surprised to know that it's estimated that approximately 4 lakh children are diagnosed with cancer. And among them, 2.2 lakh are presumed to be diagnosed. And we have what is called as the 80-20 paradox, where 80% of children live in LMICs, whereas the survival is 80% in high-income countries, and it's kind of reversed in many parts of the world. And only 11% of all data in the International Incidence of Childhood Cancer comes from low and middle income countries. And in the South Asia region, only India contributes, which is about 2% of all data. And if we want to achieve the World Health Organization's goal of 60%, that is GICC goal of 60% survival by 2030 and save 1 million children, we need to know, we need to get real data. We can't assume that we are saving so much. And one way to get this data is by establishing both population and hospital-based childhood cancer registry, which is one of the pillars of the cure-all framework as per the WHO GICC. The problem is that we do have a lot of registries in India. We have these adult registries. They focus on adult cancers. And as we know, adult cancers are different from childhood cancers. They use the TNM system. They use the ICD system. They do not capture the treatment protocols. They do not capture treatment adherence. These cancers are more focused on capturing incidence for cancers due to tobacco or alcohol. And we know that we don't know what causes childhood cancers. We know what to do after they get treated. So the focus is totally different. And since childhood cancers in some registries are less than 2 to 3%, they don't get the attention they need. And again, even if you have a childhood cancer registry, there are a lot of problems, logistical issues, space, data, good quality data managers, hospital records, lack of funding, government interest. So a lot of challenges in establishing and running a childhood cancer registry. So what are the solutions? So we need to have good collaborators. We need to work as a team. We need to train the people in collecting data and analyzing data. We need to have data, if good garbage in and garbage out, if your data is not good. So you have to have good quality control. And the most important is money. Somebody has to put in money. Registries are boring. It takes time and people really don't know what you're doing. We started this work in 2019 until we released the report in 2025. People really didn't pay interest because it's only when you release the shiny report and it comes in the press, people start saying, oh, this is something good. So people are more keen to invest in other things rather than registry. So that is a challenge to get funding. But the most important statement which I came across is that a lack of comprehensive pediatric cancer registry has been identified as the most important barrier in generating political interest in pediatric cancers. Children with cancer are not, unfortunately, are not a vote bank. So you are not going to win elections. So you have to give them data. You have to bring the data to the ministry, to the administrators, to make them understand the importance of childhood cancer. And let me take back to you to 2 decades back. We have been having a general cancer registry, and Dr. Swaminathan from ADEA published one of the most quoted paper from LMICs on the Chennai population-based registry. It had about 13,300 cases. And at the 10-year follow-up, the only 18% were alive and 26% were lost to follow-up. And this data did not have the disease stage, the socioeconomic status, compliance treatment, the treatment protocols followed, and supportive care. Basically, it was very basic data. And after that, nothing came out. And that is the reason why we thought we should have a dedicated registry which looks specifically at children, collects all the data which is missing, look at the Toronto staging classification for pediatric cancers, non-stage prognosticators, treatment details, and longitudinal data, including recurrence and second cancers. So our idea was to capture all pediatric cases in the Chennai metropolitan region for between 0 to 19 years. And we expected to capture about 175 patients with children with cancer and non-malignant brain tumors. And the registry officially began on 4th October 2022. It's interesting to know that almost a quarter of all people living in Chennai are less than 19 years old. This registry was integrated with the current population-based registry, which is the Madras Metropolitan Tumor Registry. And we collaborated, which this registry collaborates with major organizations. And Cancer Institute has played a big role in cancer registry across India, also including making cancer a notifiable disease in Tamil Nadu. Data was collected from all common private hospitals, labs. We use the St. Jude's form, which is a hospital-based form. So we are one of the first registries in the world which showed that you can have the same form for both hospital-based and population-based registry. And we followed all the IARC's quality control and reporting. And it is, as I said, it takes a village to have a registry. And we had stakeholders across India, abroad, NGOs, government, national organizations. And 19 out of the 22 hospitals are providing data to the registry, which is about 80% of all the childhood cancer data in Chennai. And we have been through various phases of specialization, engagement, initiation, and so the registry is expanding fast. We want to ensure that we collect data within 2 years of diagnosis. We want to ensure that majority of patients, almost 95%, have a verified morphological diagnosis. Very less is collected from that registry. And also, we want to compare it with other standard registries across the world. So the first report, always registry data takes time. So we have published the 2022 report. Next month, we'll get the 2023 report. And it is interesting that we had total of 241 cases of pediatric cancer diagnosed in Chennai. among which we got 170 patients with high resolution data. That is, they had all the stage and follow-up and all the data with a median diagnosis of 8.6 years. As expected, leukemia, lymphomas were the most common diagnosis. And the most majority of the cases were treated at the government ICH ECMO hospital. And this gives you the age standardized rates for most cancers. As you see, leukemia, lymphomas, and soft tissue sarcomas are common. Malignant brain tumors, CNS tumors are almost way down. We get from Western data that CNS tumors are in the top 2, but here it's not even the top 5. And when you look at the age standardized rate, it's about 136 per million per million population. This is very interesting. It shows that when you look at the left, when you compare it with Asia and South Asia, the Chennai has an incidence which is just below Vietnam. And when you look at other LMICs, we are high up there. This suggests that we are able to pick up majority of the cases being diagnosed in Chennai, and the case attainment rate is very high. If you see India is about 74. Chennai is almost double of what the incidence rate in Chennai, India is. It's not because the Chennai children are more prone to cancers, it's just that we're able to capture all the cases. When you just look at the high resolution data, 2 years of survival, 71 patients are alive, and 22% are diseased. This is when the Health Minister of Tamil Nadu released the report, and this created a lot of buzz. It came in newspapers, IARC recognized it, and as I said, we have to generate political buzz, and this gave us the impetus to spread the registry to the whole of Tamil Nadu, making it one of the largest registries in the world. We also looked at what are the difficulties, barriers which we faced, and enablers of establishing this population-based registry in Chennai. This was published in PBC. And as I said, it takes money. Thankfully, we have got funding from the Bakchi family for the next 3 years to extend this registry to Tamil Nadu. And we're also thankful to various NGOs, including Can Kids, INPOG, especially the pediatric oncology community in Chennai and Tamil Nadu, the TPPOG. They've been fantastic, and all of it's not my project or Cancer Institute project. It's our project. It's IAPPHO's project. And as I said, if you want to improve survival of children with cancer in LMIC, we need to know where we stand, and we need to collect high resolution data. And this is best achieved through dedicated both population and hospital-based cancer registry. We have started the INPOC hospital-based cancer registries, and we request everybody to join this and make it a grand success. Thank you very much. I think I'm well within my time, 30 seconds left. Thank you for the opportunity.
Thank you, Venkat. You have exactly taken around 9.5 minutes, so that's perfect for us. So if there are any, maybe one question or one comment that we can discuss before we move on to the next speaker. The format would just be the same 10 minutes per speaker, and maybe just one question in case there is a burning question, and we can discuss that. And if there are comments in the chat box, we'll try to answer them parallelly.
Can I ask a quick question, Manas, to Venkat?
Yes, please. Yes, Dr. Girish. Yes.
Yeah. Venkat, from your assessment, then the incidence what we estimate in childhood cancer in India, if you extrapolate it to the country, is lower than what we estimated?
Yes. So the Raman's paper on Indian pediatrics, if you see, it is slightly lower than what that had probably estimated about 74,000 cases, if I remember. If you look at our incident, it comes to around 50 or 56,000. But unless we cover the whole of the country, we'll never get an idea. So I think this is a beginning.
Raman, you wanted to comment on this?
No, I agree with what Venkat has said.
Okay.
So I think Chennai has probably got the most accurate incidence data in our country for various reasons, historically from Swaminathan's efforts and now Venkat's efforts. There have been extreme blips. So Delhi reporting a few years ago, extremely high incidence rate, particularly among the boys, I think is an artifact. We'll wait to see more mature data. But strengthening Chennai, which currently represents, I think, 0.4% of the Indian population, expanding into Tamil Nadu, which will then represent 4% of the Indian population, would be a huge step forward.
So thank you. We move on to the next speaker, and that is Dr. Girish Chinnaswamy. So sir will be speaking on diagnostic and prognostic potential of catecholamine in neuroblastoma, a report from the SIOP committee. So over to you, Dr. Girish.
Is my screen visible?
Yes, yes.
Okay. Yeah. So actually, I was told to take 2 papers, so I'll try to do both in 5 minutes each. But
Sure,
please
sure.
me if it is I'm running out of time. The first one is actually on treatment de-intensification of Wnt medulloblastoma, and this is a randomized trial from the SIOP PNET5 medulloblastoma study. And I put it because it's a very contemporary topic for us in India. So all of you know that medulloblastoma molecular grouping has identified low-risk disease and very high-risk disease, with low-risk disease having excellent outcome of more than 90%, and especially the Wnt one, which you can see in group C. And this data has been replicated not only, it's replicated both in AIMS and from data from TMH as well. And we also know that medulloblastoma survivors have late mortality and late toxicity, which is quite significant. And so it only is natural that there would be various de-escalation strategies for the good risk medulloblastoma, which people would think about. And these are all the various strategies which are being contemplated and tried, and bulk of it is on radiotherapy because the late toxicity of radiotherapy is quite significant. So there have been about 6 trials, ongoing trials to de-escalate radiotherapy for medulloblastoma. 2 from India, both of it from our center itself, and 4 others, 1 from COG, 1 from St. Jude's, 1 from Europe, and 1 from another group in Japan as well. So, but 2 of the trials had to be terminated because both the trials probably overstepped. One was the trial from our own hospital, Tata Memorial, where we removed the craniospinal irradiation and we realized that relapses were higher, and that the data monitoring committee stopped the study early, and it had a strong stopping rule. The other one was to do chemotherapy only strategy for Wnt medulloblastoma, thinking if there is such high good outcome, can we avoid radiotherapy altogether, because Wnt medulloblastoma's long-term mortality was due to radiotherapy and not due to other conditions. And hence, actually, the chemotherapy strategy was also tried, which also was terminated because the relapse was very good, very poor. So what you had was essentially 4 trials left, all of them decreasing craniospinal, but keeping the craniospinal, but decreasing the dose. And what I'm going to present is the last of the study, the SIOP PNET5, which got completed, and the St. Jude study is completed as well. Now, this is the study schema, and it is Stefan Ratowski and Francois, who are actually the PIs on this low-risk arm. And essentially, you had a Wnt medulloblastoma, which was R0 and M0. That means completely resected non-metastatic disease. The question was, can we actually reduce craniospinal irradiation from 23.4 gray to 18 gray and keep the boost only to the tumor bed and not to the posterior fossa, and decrease the chemotherapy from 8 cycles of chemotherapy to 6 cycles, which essentially means 3 cisplatin and 6 cyclophosphamide doses. And the secondary objectives was to see whether you look at the overall survival PFS and significantly the late effects as well. So this was the treatment schema which was done. So it all centrally confirmed medulloblastoma, Wnt subtype. They used a combination of IHC and molecular testing. It was mandatory to do molecular testing. And there are more data on that, which was presented in the paper in the late breaking abstract. And that's quite interesting. And people should go and look that up about methylation, how it identifies additional cases. And then radiotherapy was decreased for all 18 gray who are eligible patients, and they got additional 36 gray for posterior fossa, and followed by 6 cycles of chemotherapy. But the data monitoring committee also brought in a criteria that they should only do a per protocol analysis and not do the intention to treat, for the reason that many patients were getting radiotherapy more than the planned 40 days. Within 40 days, radiotherapy had to start, and some centers had continued to give 8 cycles of chemotherapy, so they were excluded. And this is what the data showed. As you can see, even in the intention to treat analysis, the 5-year EFS was 87%, and overall survival was 92%. So continue to maintain a very high survival rate by decreasing RT. And if you look at per protocol analysis, it was even better. That means if you give the RT on time, starting ideally within 4 weeks of surgery and best before no later than 40 days, and giving 6 cycles of chemotherapy, which was adequate, then your EFS at 5 years was 91%, and the overall survival was 97%, which was excellent. The significant slide of all them is actually the secondary objective. They compared the late effects of the PNET5 low risk with the PNET4 patients who received 23.4 gray. And as you can see, the number of patients who needed growth hormone was 12% here compared to 52% in the previous study. And the number of people who had hearing toxicity grade 3 to 4 was 7% compared to 16%. Of course, they got more cisplatin in the previous study, where they got 8 cisplatin courses compared to the 3 which they got here now. So when they compared it both, it was clear that these had less late effects, and the quality of life is still being analyzed. Similarly, St. Jude's brought out the study which was presented in ISPN in Philadelphia. The paper is not out yet. A very similar strategy, but they went further to decrease it to 15 grade to the very good risk Wnt medulloblastomas. And they actually have a PFS and OS of very similar 90 and 98%, which were there with an autotoxicity of 14%. So the conclusion was that is enough. We don't need to give 23.4 gray. You can decrease the radiotherapy and de-escalation. This is the summary of the de-escalation strategies which have been tried. The first one is standard treatment, 23.4 has got good outcome. Second one is only chemotherapy, 100% relapse. Third one is giving only tumor bed and not giving CSI, which was our study, 50% relapse. And the last one is actually 15 to 18 gray, still gives more than 90% progression-free survival, relapse-free survival, and overall survival. So what it means for treating medulloblastoma in India, that molecular stratification, it re-emphasizes it is necessary for us to do. And I think the low-dose cleanospinal irradiation for Wnt medulloblastoma will become the standard of care and potentially decrease long-term toxicity and mortality. So I think within the next 2 years, we'll all be recommending that we do only 18 gray CSI for the Wnt medulloblastomas who are non-metastatic and have had complete resection. I think that's the first paper. Shall I just go to the second one?
Yeah, quickly, if you can. Yeah, thank you.
So the second one is a bit more intriguing. This is actually about catecholamines, which we thought is pretty much gone out of fashion. We ourselves don't really look at catecholamines in neuroblastoma anymore. But then there is actually a committee called the Neuroblastoma Catecholamine Committee of the SIOP and subcommittee, which has been studying catecholamines for a very long period of time. And these are all the various studies they have done. Can we look at multiple catecholamines, blood versus urine, 24 hours versus spot urine, etc., etc. And they found that if you actually do a battery of catecholamine tests, your diagnostic accuracy is better. But more importantly, they found that one of the metabolites, which is 3-methyltyramine, at diagnosis, if they're elevated, and have a very poor outcome, even in an NMIC amplified neuroblastoma, there's a difference in outcome. And it became an independent prognostic factor only in 2 small subgroups at Princess Maxima and another hospital where they checked in a small number of patients that it was found to be significant. And then they did a retrospective study of 140 patients on the DCOG trial. And in the retrospective study, they had collected samples of urine and tested, and they put the data together. And what they saw that there was no difference in survival if the urine catecholamines were elevated at diagnosis or no, when they used these 8 points, 8 urinary catecholamines, post-induction, post-consolidation, or at end of treatment. However, what they found interesting was whenever you call the patient a CR, usually it is post-surgery for us or post-high-dose chemotherapy. If the catecholamines were elevated at that point, then the relapse rate was very high. So it actually predicted relapse in those who were in CR but had raised in urinary catecholamines. So when they did the analysis, they found methoxytyramine to be the most useful, strongest predictor of relapse. And when they did a multivariate analysis taking NMIC, age, and time to reach CR, etc., they found that the positive urine status of 3MT predicted a poor outcome even in a multivariate analysis. So they actually have brought an intriguing question back that whether actually urinary catecholamines is still useful today to do and what it means for routine practice. See, one, it is available and it can easily be done. This is a retrospective data, although it's interesting, which tells us that high urinary catecholamines, when you achieve CR, if they're still there, relapse rate is high. And maybe you can intensify therapy with newer treatments coming up. But I think it's a prospective study required to validate the results. And it's something which can easily be done in India to validate that. I think those were my 2 cases, Manas. Thanks.
Thank you, Dr. Girish, for these very crisp presentation and 2 very important studies. Any comments or questions?
Your slide suggested that less than 5% for 23.4 and less than 10% for 15 to 18 gray. So there's, looking at the slide, you would say, oh, well, there's a few percentage points here. What's the conclusion?
So the conclusion is that because, the conclusion is that if you achieve more than 90% outcome, which was the initial aim was to even achieve an EFS of more than 80%, and they hit 90% in per protocol analysis, that was adequate what we were reaching, though we had about 3 to 4% difference compared to giving full 23.4 gray. And same thing in the Senjutsu as well, because the late effects are significantly higher, which leads to late mortality. So the hypothesis is that if you actually have less late effects, and the late mortality is also less, and overall long-term survival will be better.
I just
And
have one
just
comment. This is
yeah.
Dr. Satya Yadav. So,
Yeah.
Girish, wonderful presentation. So, in medulloblastoma, as we reduce the radiation, probably these patients might tolerate chemotherapy better. They will have less breaks in their chemotherapy, and
Yeah.
that may provide intensity and may improve the outcomes. That's one thought in my mind, because when you give them the full dose, many of them, they don't tolerate chemotherapy very well, and there are frequent breaks, and you have to reduce the dose of chemo or give longer breaks. So the intensity is lost. Like St. Jude's protocol, it's not very well tolerated by many patients if you try to give them that intensive 4 blocks after big dose of radiation. And in fact, St. Jude's has reduced the SJMB, they have reduced the dose of cyclophosphamide in the current protocol from the previous one because of the toxicity. So this is one aspect. Another is that if proton therapy is given, I've observed the side effects are less. Of chemotherapy is better tolerated. So again, that these are the other aspects of radiation. Maybe the dose or the mode of radiation might be important, so that the proper intensity of chemotherapy is delivered. Thank you.
Yeah, no, both points well taken, Satya. That's very practical as well. That if you give full dose craniospherical radiation, then delays in chemotherapy is more.
Yeah. So thank you, Dr. Girish. I think there is a couple of questions on the chat. You can probably answer them in the chat box. The next one is Dr. Maya Prasad. Dr. Maya will be speaking on the clinical utility of dysregulated microRNA expression in pediatric cancers. Over to you, Maya.
Thanks, Manas. Yeah. Sorry. So I think my slide should be okay, visible properly.
Yes, they are visible. Yeah.
So good evening, everyone, and I will be presenting a keynote lecture. I mean, I'm not doing the keynote talk, but I'll be presenting the talk which was done as a keynote talk. And actually, it was a huge challenge for me to even understand most of it, but I found it extremely interesting, and I thought it would be of general interest, which is why I chose this topic. So first of all, to refresh what actually microRNAs are, I'm sure we'll now start recalling that these are short non-protein coding genes. So they do not code for proteins, but however, they regulate the expression of messenger RNAs, and therefore indirectly they contribute to the coding of they contribute to the regulation of a lot of the protein coding genes. And they play a key role in cancer development, as we are learning more and more. They can both be proto-oncogenes and they can be tumor suppressor genes. So a couple of things from the biogenesis of mRNAs, microRNAs, which I think we should remember for the purpose of this talk, are that one is that they are usually present in clusters. So during their biogenesis and maturation, they often come in clusters. Secondly, the dicer protein is actually very important in the pathway of microRNAs, as you'll see later. And thirdly, once the microRNAs mature, they integrate into their target messenger RNA. And the primary role is that once they integrate, they lead to messenger RNA degradation or translational repression. So once this any part of this pathway is dysregulated, it can lead to oncogenesis. So that is the importance of microRNA. So there have been lots of studies over the past 2 decades, and this heat map actually shows how the tissue clusters, actually the development of the tissue, or the ontogeny of the tissue, is very important because they all cluster together according to their the microRNA expression actually clusters together depending on the development of the cell. This is very important when we come to the next part, which is about the germ cell tumors as well. So here you can see that all the mature adult tumors actually cluster together, both within the normal tissue. You can see that these are all the colors of the adult tumor tissues, and within the tumor also. So the different tissues really cluster together based on their developmental origins. And this is the same for malignant GCTs as well, because the GCTs tend to cluster together. Another important thing is that as I said earlier, generally in most cancers, microRNAs are actually down-regulated or underexpressed. But the tumor type in which microRNAs have been studied the most are germ cell tumors. And interestingly, in germ cell tumors, especially in malignant germ cell tumors, these microRNAs, specific microRNAs, tend to be overexpressed. So this is what has been very important in this entire all the studies that they've done, that these are overexpressed, and specifically certain microRNAs. And there are two clusters. So the microRNA 371 to 373, which come together as a cluster, and some of them which are 302 and 367. So although 302 looks really far from 367, it's all on the same chromosome. So it's another cluster. So these are the two clusters which are commonly overexpressed in malignant GCTs. Again, the heat map shows that the malignant GCTs cluster together, and the teratomas and the controls, the green and the maroon, actually the benign kinds, they actually cluster together. So all of this is important because it is useful in the diagnosis. And here again, in normal tissue as well as in benign germ cell tumors, these microRNAs are underexpressed. And in all of these malignant germ cell tumors, it is overexpressed. So why is this important? This is particularly important because we all know that in various germ cell tumors, although tumor markers are extremely useful and very, very important in the diagnosis, follow-up, etc., certain tumor markers are expressed in certain histological subtypes, and in some of them, they're actually not expressed at all. So they do not help in seminomas and embryonal carcinomas. Whereas in that is actually one of the drawbacks of using regular tumor markers in germ cell tumors. So because of that, you can't even use it to detect relapses, especially in seminomas or in the non-secretory, in the typically what's termed non-secretory germ cell tumors. But microRNAs are overexpressed in all types of malignant germ cell tumors. So independent of the histological subtypes, including in embryonal carcinoma and seminoma, they are actually overexpressed. And this is because, as we all know, all the germ cell tumors have got a common developmental origin. They all arise from the primordial germ cells. And in microRNA expression, it's actually the developmental origin which really determines its overexpression. So which are the microRNAs? There are specific microRNAs. So there were many when I showed you earlier, but studies have further refined. They found that this cluster of 371 to 373 and then this 367 were the most important, but further there are multiple small cohort studies, but some multinational studies as well, which found out that this microRNA 371A, which encodes for 3P, is actually the most optimal single marker. So we found that they are elevated at diagnosis across most germ cell tumors. But here we can also see that just like the AFP in this particular case, just like the AFP, the microRNAs also are elevated at diagnosis and come down with treatment. And in this child who is in remission, they continue to stay at a low level. Not only in gonadal or extracranial germ cell tumors are they important, they're also important in intracranial germ cell tumors. So CSF microRNAs are elevated in intracranial germ cell tumors, the malignant ones, and they actually are quantitative. So a big tumor will actually have a higher level of microRNA. A smaller tumor has a lower level of microRNA, and a benign glioma, which is not a germ cell tumor at all, does not even have there. It's actually underexpressed, like it is underexpressed in most other tumors which are not germ cell tumors. So multiple studies, I'm sure you've all heard of or read of many of these studies, but most of them have pinpointed the same few microRNAs, and most of them have specified that this microRNA 371 is the one to watch out for. So this is also important in surveillance because just like our other tumor markers. So here again, they came down with treatment, and when the microRNA was elevated, a scan showed that there was actually a relapse. And again, treatment brought it down, and fortunately for this particular patient, it continues to be down. This is very important. So we might ask why, because yolk sac tumor AFP does the same thing. But this is very important in other tumors where the tumor markers are not elevated, especially in the case of seminomas. And also because the half-life of mRNAs, microRNAs are far less than AFP or beta HCG. So so they tend to normalize much sooner. It may just take hours or a few days to normalize. And similarly, they rise also much faster when there's a recurrence. So there was a study in adult seminomas which found that the recurrence was detected 2 months earlier with the microRNAs as compared to a CT scan. So this, as most of you may know, is being incorporated into the recent COG-GCT trial for both disease monitoring and relapse detection. It does not actually have a therapy component, but it's being used for the surveillance. Also in a UK germ cell tumor study. And in fact, because most of the work surrounding this has been done in the UK, they are standardizing this test so that it can be incorporated into the NHS. And a study of the cost analysis based on the NCCN recommendations found that there was a huge cost savings which could be actually done if we used mRNA instead of CT scans for surveillance. So that was for GCT. I think the role in GCT is, it's quite solid now. But there are other solid tumors as well, in which there is an emerging role of microRNAs. And one such tumor is MICN amplified neuroblastomas. So specifically in MICN amplified neuroblastomas, probably because they have got a higher tumor burden as compared to the body weight of the child, and so the microRNA levels are high. So that was the hypothesis given for that. And specifically, it is this microRNA 124. Again, here, these are all just single case studies at diagnosis high, but at the end of induction therapy low, and then continues to remain low. Unfortunately, in this child who was also undergoing serial assessments, it went down, but in the CSF it came up, and then a scan found that there was an intracranial relapse. So other tumor types also have got some, there are several studies, but nothing that's very robust yet. So why would we actually want to use microRNAs as a biomarker? So one is that they're very good. Technologically, they're very easy to use as biomarkers. They're highly resistant to degradation. Even after collection, they do not, they're protected from, in the plasma, serum, etc. The values remain stable. It's a stable kind of test. So technically, it is an easier way of doing it, and it's a more robust kind of thing of doing it. Also, childhood cancers have got a low mutational burden. And while in adults, ctDNA or circulating DNA is used a lot, in children, the use is limited because the mutation burden is low. So maybe it could be, microRNAs could be another way of doing it. So these are all the potential, implications of microRNAs. So therapy is something that's emerging. All studies have shown that generally the dysregulation of microRNAs tend to converge on the cell cycle. And based on these mechanisms, several interventions have been done. These are all preclinical and on cell lines, but there seems to be some effect. There are preclinical studies which have utilized microRNAs, all in advanced adult solid tumors, but they're all phase 1 studies. And they've all been used as monotherapy. They have been effective, but very short-lived effect, like in most phase 1 trials. And immune-mediated reactions are prominent. So there have been a lot of adverse and serious adverse events on these trials. So lots of people are working on it. So hopefully these will eventually start getting incorporated into treatment soon. So just to summarize, so microRNAs definitely have a role in the diagnosis, especially in germ cell tumors, and hopefully in high-risk neuroblastoma as well. Prognostication, yes. I mean, there seems to be a role, but we're not yet quite sure. It does show the tumor burden, so maybe. Monitoring, definitely a role in GCTs. So I think definitely that's going to be something that's going to be more and more used. Therapy, not yet there, but hopefully in the future. So thank you very much. I think, although I presented this is all the work of Matt Murray and his very large team at Cambridge and all his collaborators. This particular review was extremely useful for me. And whoever is interested, I would suggest that you read this. It's a couple of years old, but very good. Thank you.
Thank you, Maya. Not only you presented a study, but also gave us an overview of what these microRNAs are. I think we are running a bit short of time, and I'll request speakers to stick to 10 minutes. Nitin, you are next. But just before that, I wanted to ask if Dr. Regin Kebudi is in the audience. Dr. Regin, if you are there, please unmute yourself. She emailed saying that she will probably be around at around 7, but I guess she must be stuck somewhere. So if Dr. Regin is not there, we'll move on to the next speaker, which is Dr. Nitin James Peters, who's going to speak about a couple of, he has sent a couple of abstracts. So we'll see what Dr. Nitin has to present and what he learned from Amsterdam.
Hi, Manas. Thank you. And thank you, team PHO. Am I audible?
Yes, you are audible.
Okay. So I was not very sure, like I spoke with you and Anand also. So I took out actually 3 abstracts, but I'm going to do just 2 because I think the time is not there. And both of them were from the neuroblastoma sessions, and I thought they were relevant to our kind of practice and the things we do in India. So the first paper was presented from Westchester, New York, and that was talking about malnutrition and its association with increased surgical complications in children with neuroblastoma. So yeah, so there is very little background work actually on surgical complications and socioeconomic disadvantage in children per se, and absolutely no literature on children with malignancies. So, but definitely poverty and surgery has a very, very converse association, which is quite logical. And we see a lot of problems in children who come from lower socioeconomic strata. So the background and aims of the study was that malnutrition can affect both treatment tolerance and toxicity, but has some impact on surgical outcome, which is really unknown. So they aim to determine the effect of malnutrition on surgical complications in these children. So it was a multicentric study over 12 years, and they looked at the data from the North American Surgical Oncology Consortium, and they defined malnutrition as undernourished, overnourished, and normal nourished as per WHO definitions. They also took a surrogate marker of hypoalbuminemia less than 3.4, which they used as a secondary measure, and they looked at intra and post-operative complications. So they had a cohort of around 1,600 patients, and very different from our kind of patients which we see. So a good almost 55% were normally nourished. They were normal in their metrics, and only less than 5% were undernourished, and there was a significant amount of overnourished children who classified as malnutrition. So it was significantly associated with return to surgery and unplanned reoperations. The undernourished had 5.7 reoperations, and the overnourished had 2.6% reoperations as compared to the normally nourished children, which was just 0.5%. And logically, they said that the chyle leak was much more common in the undernourished children, which is very, very, we see this in our practice also. And this was also statistically significant. They saw that hypoalbuminemia was present. I mean, they could have only 25% patients in which they had a diagnosis of hypoalbuminemia, and it really affected the enteral feeding post-operatively. And we see this in other surgical conditions also. So low albumin levels will deter the enteral feedings and cause problems in recovery of these children. So out of these 1,600, they had data for around 947 patients who underwent tumor excision. And out of these children on this histogram, you can see that almost 65% were normally nourished who underwent surgery. Surgery was on a mean done 30 days after diagnosis. And out of this groups, around 16% had hypoalbuminemia. And these patients had significantly different and intraoperative and postoperative complications who had hypoalbuminemia. So they defined these as various things like Clavin-Dindo surgical complication classification, and they looked at blood transfusions, they looked at surgical site infections and a lot of other things. So, it was quite interesting to see that there is an association. Surgeons have been using albumin for a long time, maybe 30, 40 years. Never it has been validated, and this study had done it quite well. So they concluded that malnutrition was associated with an increased surgical morbidity in children with neuroblastoma. And the diagnosis and correction of malnutrition, which can be, I think, challenging at the time of this diagnosis, may improve surgical outcomes and help in adjuvant therapy, early initiation of adjuvant therapy. That's the first abstract. So, Manas, should I just go on to the next or wait for any questions?
Yes, please. I think we can go on to the next and then we can have the questions at the end.
Right. So I'm actually at a meeting in Delhi at AIIMS, which is the Pediatric Endoscopic Surgeons meeting. So there's quite an interest in 3D vision in neuroblastoma surgery, whether it increases, and it's useful in minimal access or laparoscopic surgery. This is from Sabina Itan in Paris and the group at Department of Visceral and Neonatal Surgery at Paris, France. So they do quite a bit of this, and they do robotics also for children with pediatric malignancies. So minimal invasive for neuroblastoma has gained traction over the years, and it's not just the presence or absence of IDRFs in which surgeons would decide for minimal access, but they generally rely on tumor size. Laparoscopy, which is abdominal surgery, and thoracoscopy, which is thoracic minimal access surgery. It can be done that usually the laparoscopy system has a 2D system, a two-dimensional system. Robotics has a three-dimensional system, which gives much more depth perception. But now most of the newer laparoscopy sets are coming in with a 3D, you can interchange it. So the aim of this study was to determine if change from 2D to 3D would help in pushing the indications for these minimal access surgeries. So we all know this proposal guidelines, which was given by the IPSO group and SIOP and IPSO group, which looked at certain guidelines, and they essentially said that the IDRF is not really a set in stone kind of a thing, and you should look at volumes of 75 to 80 ml, and some people said 60 ml tumors. So this I've just taken from a urology paper because this shows the picture on the left is a normal two-dimensional laparoscopy where you would see a blurry kind of image. I think most of the physicians would think it's quite blurry, but all of you would be able to appreciate the kidney and the renal hilum very clearly in the three-dimensional picture. You can actually see the you can actually see the hilum here. You can see the kidney parenchyma. You can see the girotas and everything, and the ureter here. So that's how 3D is beneficial. And just a minute. Sorry. So they looked at their 10-year data, and they looked at abdominal and thoracic neurogenic tumors. They did not, they disregarded metastatic and molecular status for this study. So they had a total of 104 patients, out of which 18 were operated by the open approach, which is a laparotomy or a thoracotomy, and 86 by the minimal access approach. And the median age at surgery was 2.7 years. So when we looked at the adrenals, paravertebrals, and perivascular neuroblastomas, so the blue is the open surgery. So, most of the adrenals were having open surgery. But when the people shifted to minimal access surgery, the paravertebral and the adrenal almost had similar minimal access approach in the 2D. And when we reached three-dimensional, when they started doing three-dimensional surgery, they said that they saw that their indications for adrenal surgeries at least was also almost coming as close to open surgeries. Yeah, and when we looked at they looked at metastatic and L2 lesions, so they said they saw that the L2 lesions will focus on that. So almost 30% of L2 lesions, 30% of L2 lesions were um, done in the open way, and whereas when they tried it in a two-dimensional, it was a little higher, maybe just below 40%. Three-dimensional, they were IDRFs for two-dimensional and three-dimensional minimal axis. And they further classified where the IDRF was positive in the abdomen. And when there was an IDRF on the celiac trunk or the SMA, then there was no laparoscopy. Obviously, everybody would go in open. And sorry, the second row is three-dimensional. It's a typo there. When there was an IDRF on the aorta, the 2D laparoscopy was done in around 10% patients. And when they used a 3D, they could, enhance that to around 30% patients. When there was an IDRF on the renal pedicle, so in two-dimensional, they did around 48%. Not really statistical different, but yes, there was improvement. The operative time was slightly higher in 3D because of surgeon fatigue, because you have to wear those, the 3D glasses like you wear in the movie halls, and it can strain your eyes for some time. But other than that, the residual tumor volumes and the complications were same. So they said that once we use MIS, the vascular IDRFs, it's easier to take care of them. And a lot of more indications, you can actually push the envelope and do more of minimal access and give benefits of laparoscopy to these children. Thank you. And SIOP is always a good time to meet up friends. And this is the Indian contingent this time, and very few people were there because of Diwali. So thank you, and I'm happy to take questions.
Thank you, Nitin. And we can see Dr. Gali Divya, who actually got the R.K. Marwaha Award this time, and she presented her research at FOCON 2025 in Manipal this time. So thanks for doing that. And if there are no questions, I think we'll move on to the next speaker. The next speaker is Dr. Ramya Upulri. She'll be speaking on approach to high-risk infant medulloblastomas. Ramya, are you there?
Yes, sir. Can you hear me, please?
Yes, we can.
And
we can hear you.
You can see the presentation as well.
Yes, very well. Yeah, thank you.
It's going to be quite short because it's only one topic, but it was a very interesting talk by Dr. Lucy Laffey-Cousin from in Canada. So she presented specifically on infants with high-risk medulloblastoma. So this is just to give a background. We have so many trials happening in infants for infant medulloblastoma, and a lot of us follow the Head Start 3 or the Head Start 2 trial, as well as the COG trial, which is the ACNS 0334. This is the background of the COG trial, which includes 3 cycles of induction, followed by 3 cycles of high-dose carboplatin thiotepa with stem cell rescue, along with the addition of high-dose methotrexate during induction, specifically for group 3 and group 4 infant medulloblastomas. So this is what is a summary of what Dr. Lucy had put forth during her session. The COG is now coming up with the COG Next approach, which is building on the basis of the ACNS 0334, where there is more and more focus on clinical and molecular risk stratification to divide children into high risk and very high risk. And all of this is basically to risk stratify the dose of radiotherapy and delay radiotherapy as much as possible, because we know in infants you do not want to expose them to radiation. So in the high risk group, which includes the group 3, group 4 with M0 and R0 or R+, which is residual plus or minus, they are going to add the new agent during induction based on the molecular markers. So we know that there are newer agents for SHH. There's newer agent based on the molecular markers that are being tried, targeted therapy. So the plan, their protocol would include those during induction. as well as in maintenance post high dose chemotherapy. In the very high risk group, the risk stratification would include group 3, group 4, and those with metastatic disease or with MYC or MYC-N or isochromosome 17p. In these, they would add the newer agent during induction along with IT methotrexate and in maintenance post transplant. The response, so radiation will be response based using imaging and CSF cell-free DNA. Wherein those more than 18 months of age, 18 gray CSI would be used, while if they are less than 18 months, they would either give additional maintenance and then give the 18 gray CSI such that to postpone radiation as much as possible. The St. Jude infant medulloblastoma 21 trial was another trial which she spoke about, where again, the children are classified into low or average risk versus high risk. The low or average risk children would include those with, and this is only infant medulloblastoma, would include the SHH1, SHH2, which will be determined based on methylation, and they would then receive no radiotherapy at all. And the high-risk group would be the group 3, group 4, where systemic chemotherapy would be continued until 3 years of age, and at 3 years, risk-adjusted CSI would be determined based on the metastatic status, mixed status, and the response to chemotherapy. If it is M0 non-MYC amplified with complete response, 18 gray CSI is what they are planning. If it's M plus with non-MYC amplified with good response, the CSI would be 23.4 gray, and with M plus or MYC amplified without a good response, they would go ahead with the 36 gray CSI. The TRIUMPH study, which is the prospective international SIOP Europe and PNOC phase 2 trial, is another study which she spoke about, where they would include infants and young children with high-risk medulloblastoma. Induction here would be based on 3 cycles of either Head Start 2 or 4 induction chemotherapy. If there is complete response, then go ahead with the transplant, if autograft. If not, give another 2 additional cycles based on the same protocol. The transplant would be randomized between 2 high-dose chemotherapy with autologous stem cell rescue with single drug thiotepa versus 1 HDCT with carboplatin thiotepa and etoposide with ASTA with autologous stem cell rescue, followed by radiation again to be adapted based on the age and the response to therapy. And as I spoke in the previous slide as well, in those who are less than 3 years of age, the presence of M0 or M plus disease with or without residual disease would determine the dose of CSI. So the consensus recommendation which she spoke about, this is actually already published, but she mentioned this in her talk, was the risk groups for children who are less than 3 to 5 years. Specifically, she spoke about high-risk group patients, which would include TP53, mutant or MYC amplified tumors. And those patients would, as I mentioned earlier, would receive the Head Start followed by transplant. So this is a summary of the ongoing strategies specifically for high-risk infant medulloblastomas. And the age groups have differed between the trials. The St. Jude takes the age as less than 3 years, COG less than 4 years, and SIOP TRIUMPH 0 to 3 to 5 years of age. And as I mentioned, the risk stratification would be the group 3, group 4 would all be high risk, but the very high risk would be those who have MYC amplification without a good response. And all of this is important to determine the dose of radiation. In the high dose chemotherapy is a main component of therapy in the COG and the SIOP TRIUMPH trial. However, St. Jude's is going for conventional chemotherapy with CSI. So the summary of her talk was that this is what was her last slide, to say that group 3 and group 4 are higher risk group with SHH. However, there is poor prognosis associated with any MYC amplification, whether it's NMYC, CMYC, including isochromosome 17q for the group 3 and group 4. Poor prognosis associated with TP53 and MYC-N for SHH, and variably to integrate extent of resection, metastatic status, histologic type, and response to therapy in determining the amount of CSI. And of course, to do neurocognitive monitoring. Yeah, that's it. Thank you.
Thanks, Dr. Ramya. So we have time for one question, if at all. I don't think we have any questions at this point of time. So thank you, ma'am. So yeah, we share two abstracts about retinoblastoma. So one on stratification and one on treatment of CNS involvement of retinoblastoma. So I welcome Rachna ma'am to deliver the next two, to discuss next two abstracts. Thank you. Rachna ma'am, over to you.
Good evening. I hope I'm audible and my slides are visible.
Yes, ma'am, you can please go ahead.
Good evening, everybody, and thank you for this invitation. So, I'll be covering two interesting abstracts from on retinoblastoma, which I found important and informative, and I hope the audience also finds it useful. So, if I look at the entire spectrum of abstracts, about 30, a little over 30 abstracts, and a keynote was presented in SIOP 2025. And the focus areas were various center profiles, outcomes, a lot of emphasis on molecular basis, genetics, biomarkers, innovation. For example, there was a study on scleral patch, triple sheath interactions, advanced disease, particularly focusing on CNS retinoblastoma and the role of liquid biopsy and late effects. So I'm going to focus on two abstracts, one on liquid biopsy and one on CNS retinoblastoma. So we all know that retinoblastoma forms one of the index cancers of the six cancers of the WHO GICC initiative. And it is some glaring facts about retinoblastoma is of the 9,000 new cases annually, about India shares about 1/4 of the global burden, and a lot of discrepancies or disparities are there between survival between high income and low income countries, both with respect to the extraocular and intraocular disease. And it is not surprising to know that retinoblastoma is contributing almost 5% of cause of childhood blindness. But also the outcomes of retinoblastoma are unpredictable. There are various reasons. Of course, we know that high income countries are doing pretty well, but there are various reasons for unpredictability of the outcomes, particularly the focus being on genetic heterogeneity. Mosaicism plays an important role. Big amplification is coming in a big way because earlier we were focusing only on RB1 gene, but now BICAN amplification particularly reflects the various aggressive type of retinoblastoma, which is very difficult to treat, harder to predict. And of course, there are other clinical presentations where advanced disease, latency of presentations, and various anatomical and pathological features like vitreous seeding, vitreous seeds which are difficult to treat, certain histopathological features, particularly the microscopic invasion of optic nerve, massive choroidal invasion, macular involvement, and lastly, the various unpredictability with respect to treatment related variables, because there is lack of uniform protocols and also toxicity of various interventions like intraarterial chemotherapy, and of course the global inequities that is well talked of. So also we know that with advances in retinoblastoma, there is an increasing intent to go towards ocular salvage rates. But at the same time, this limits the access to histological and genomic information, which is traditionally obtained from enucleated eyes. It is also true that whatever genomic information that we are obtaining from enucleated specimens, also this represents heavily pretreated eyes, which are often refractory and recalcitrant to treatment. So then there is this role of where does biopsy stand in retinoblastoma management? Of course, the fine needle aspiration biopsy, it is an absolute contraindication because it promotes extraocular disease spread and of course lowering survival. Hence comes the role of liquid biopsy. It is safe and minimally invasive, and where very small volumes are sufficient to obtain relevant information, and the aqueous humor forms a very logical and easily available tissue for which can be used as liquid biopsy. It can detect cell-free tumor DNA, that is, and it circulates in the entire globe, and it provides real-time insights into how the tumor is behaving. So it is a tissue that is obtainable. It has a role in diagnosis because it confirms the genetic basis. You can easily differentiate between hereditary and non-hereditary forms. It forms a mode to prognosticate because it can identify the highly aggressive forms. For example, chromosome 6p gains, the MYC amplification are associated with very poor outcomes. And of course, then you can predict that these are the tumors which are going to require early enucleation. And of course, it forms a mode that it, for treatment monitoring, that in serial sampling of aqueous humor can be done to predict the response to treatment and form something like a biomarker. So then this comes to the first abstract, was the harnessing aqueous humor, circulating tumor DNA for retinoblastoma stratification, and the work was done in Germany and Thailand. The essence of which was the aqueous tumor derived circulating tumor DNA enables molecular risk stratification in retinoblastoma without the conventional tumor biopsy. So as I told you, extraocular spread is very common once we indulge in open or FNAB for retinoblastoma. Also, if you don't have biopsy, then you limit the molecular analysis based risk stratification that is essential or that would help in outcome prior to enucleation. So aqueous humor was a logical tissue. So these scientists, these authors of this abstract did the study to evaluate aqueous humor derived circulating tumor DNA as a liquid biopsy for molecular profiling and risk stratification in retinoblastoma, essentially to establish a methodology for circulating tumor DNA profiling, which was by sequencing and methylation. They used about 18 enucleated eyes with retinoblastoma and paired samples of aqueous humor as a liquid biopsy source was used, and a corresponding enucleated sample which formed the tumor tissue was used. Molecular techniques used in this study were that was the extracted circulating tumor DNA from the aqueous humor, and this was subjected to two methods like low coverage whole genome sequencing, which is a cost-effective rapid technique of sequencing, but it sort of picks up only small portions from the entire genome, and also DNA methylation profiling was used. And this data that was obtained from the extracted circulating tumor DNA from aqueous humor was compared with the genomic and methylation profile landscape that was obtained from the matched tumor DNA that was obtained from the enucleated sample. So as you can see, there is this tumor, and this breaks off the tumor fragments and easily goes into the entire eye, into the aqueous humor, and here you can easily aspirate. And this is said to not, lead to any extra, spread of tumor into the sinus or to the tracts wherever the needle has been inserted into the aqueous humor to extract the aqueous humor. And there was another added advantage to this study was that they also wanted to explore the ability of the circulating tumor DNA to predict RB methylation clusters, because we know there is this concept of methylation clusters, and this identifies certain tumors, certain fragments of retinoblastoma which will do poorly versus who are going to do well on treatment. So this would depend on the methylation cluster profiling. So this was an added objective of this study. So what they found was that there was high concordance between circulating tumor DNA from aqueous humor and the primary tumor DNA in both with respect to methylation patterns as well as genomic alterations detected by the sequencing. And the methylation profiles reveal consistent epigenetic modifications with respect to the sample obtained from aqueous humor as well as from the enucleated sample, allowing the correct prediction of RB molecular group so that risk stratification would be possible prior to enucleation. So the aqueous humor was a potential reliable surrogate for the tumor tissue in retinoblastoma, and methylation profiles also reveal consistent epigenetic modifications in this study on the 18 samples that they studied, supporting the accuracy of aqueous humor derived circulating tumor DNA that it reflects tumors' molecular characteristics. So if you look at the critical commentary, the strengths was that it was an elegant solution to a long-standing clinical limitation of obtaining a gold standard, that is a biopsy, to study retinoblastoma and resort to some form of molecular risk stratification prior to enucleation, and it integrates also genomic and epigenomic profiling. Limitation was, of course, that was a small sample size, and of course we needed enucleated sample for this. So of course it cannot be, this study could not be replicated in situations where we don't have a enucleated specimen. The context was that there have been previous studies by people who have studied this liquid biopsy in various situations, and various biomarkers have been studied, but this needs to be validated in future more robust studies. But what was more important in this study, the newer concept was the methylation based stratification, which will also predict which tumors are going to do well versus which are going to behave poorly with respect to treatment. So future direction, if we look at it, that integrates the, it can be integrated into the treatment algorithms for eye salvage and therapy monitoring. So to summarize, there was high concordance between the genetic and methylation profile. the researchers also, try to predict specific methylation clusters, which is important to realize to predict the tumor behavior. And by just looking at DNA mutation, the study analyzed methylation patterns to capture more complete picture of the tumor's behavior. If we look at the clinical significance, it has a role in risk stratification prior to enucleation, precision medicine because it can a genotype-based therapy or genotype can guide what treatment modality has to be used, which are going to be the more aggressive tumors, which will require enucleation, and of course monitoring response to treatment because serial evaluations can be done with respect to the sampling of aqueous humor if it is required. So we have a clinical problem. We have the aqueous humor which can be easily obtained, and of course we did compare it with the enucleated sample in this study. We have a battery of molecular tests that can be done, and of course we have then the clinical impact would be for risk stratification and precision therapy, and of course we would reduce over treatment in many situations and predict better outcomes for these patients. So if I have time, I could just quickly go to the other study. Dr.
I'm within 5 minutes, ma'am. We're already running late. Yeah.
So this will be very short. So the other study that I found interesting was on stage 4B retinoblastoma, because most of us, when we see stage 4B retinoblastoma, often the intent is to palliate these patients. So this study I found interesting was that retinoblastoma patients with CNS involvement have curative chance with combination of high-dose chemotherapy and craniospinal irradiation. And this was done in Japan. So we all know the background that, of course, there are no established standard care protocols for CNS retinoblastoma, and historically the outcomes have been poor. And the authors of this abstract describe the clinical features and also the impact of treatment intensity on survival. And if you look at the IRSS staging, we were dealing with the 4B stage, which was the CNS involvement in retinoblastoma. So they did a retrospective review from 2005 to 2022. Electronic medical records were there and in a tertiary center. And they defined CNS-RB as they took two components. One was at diagnosis stage 4B and another was relapsed retinoblastoma with CNS involvement, and they excluded all trilateral retinoblastoma, and the outcome was overall survival, and they analyzed it on a EZR statistical platform. So what they found was that of the 992 patients over the study period, only 16 had CNS retinoblastoma, and the age was median age was 21 months, 50% were bilateral. But if you look at stage 4B at diagnosis, there were only 2 patients, and I'll tell you the outcomes of these. And these were treated with high-dose chemotherapy followed by autologous stem cell transplantation, and these both have been disease-free. But in the abstract, the period of follow-up has not been mentioned as to how long these patients have been, but definitely they have been disease-free. And if you look at the other category of relapsed CNS retinoblastoma, there were 14 patients, and they divided these into 3. One group was offered best supportive care of about 4 patients, all died within a month. 2 were offered palliative radiotherapy, but 8 were treated with a curative intent. So of these, we have data on 5 patients. So 2 of the 5 patients were treated with high-dose chemotherapy followed by autologous stem cell transplantation with a thiotepa-based conditioning and craniospinal irradiation. And 2 of 5 patients are disease-free. Again, the median period of follow-up is not known, but of course we do have data on overall survival. And of the 8 patients, data on 3 patients is not available in the abstract. So 3-year overall survival of the relapsed CNS retinoblastoma was 14.3%. So if you look at it critically, that there is a role of combined systemic and CNS directed intensification for these, and it is consistent with some fewer prior small series which are available. And thiotepa based conditioning is biologically plausible and because also it has excellent CNS penetration, and role of craniospinal irradiation aligns with the historical medulloblastoma like treatment. It did have limitation of a small sample size, but in CNS retinoblastoma, we don't expect large samples. And there was a selection bias because they offered best supportive care to, I think, those who were not functionally well. And it does contribute to data that contemporary data does support curative potential in relapsed CNS retinoblastoma using modern transplant-based strategies. And CNS retinoblastoma should not be considered uniformly palliative, and there is an option to treat them with high-dose chemotherapy followed by transplant and craniospinal irradiation. So with this, thank you, and I would be happy to take any questions.
We shall take the questions on the chat box if possible, because we are already running late. We will go to the next speaker. Dr. Parag Das would be speaking on the experience of icicle from India. So, Parag sir, over to you.
Thank you. I'm sharing my screen. I think my slides are visible. Okay, I'm starting.
Yes,
Good
sir. Please go ahead.
evening.
Yeah, please go
Yeah, good evening, everyone. I'm going to present the result of the first randomization of the Icicle LL14 trial. So let me provide some background. Treatment-related death remain a major challenge in improving outcome for childhood ALL in India, where the induction contribute more than one-third of the incidence of toxic death during the ALL treatment. To address this, the Indian Collaborative Childhood Leukemia Group was formed, and the Icicle LL14 trial was designed. Our hypothesis was that a shorter course of induction prednisolone could reduce both treatment-related induction death and severe non-fatal induction toxicity without compromising the treatment outcome. This is an open-label, multicentric, randomized controlled trial conducted across 5 major centers in India. Enrolled patient aged between 1 to 10 years with a newly diagnosed provisional standard and intermediate risk B-cell precursor ALL. Now coming to the study design, all data collection and randomization were performed remotely through a secure web-based electronic database system. The randomization used permuted block design with variable block sizes and 1:1 allocation stratified by both center and risk group. Eligible patients are randomized into two arms based on their prednisolone treatment schedule. The the long played represent the traditional approach where patient were received 35 days of continuous prednisolone. In contrast, uh, the short played arm represent experimental approach where patient were received 21 days of prednisolone in a pulse schedule. Patient were recruited from October 2016 to August 2022 and followed up till March 2024. The primary endpoints were treatment-related induction death and severe non-fatal induction toxicity, whereas the secondary endpoint include complete remission rates and minimal residual disease level at the end of the induction, as well as the event-free survival and the overall survival. So here is an induction treatment schema for the DCPLL patients in the Icicle LL14 protocol. We choose to randomize only the children with less than 10 years of age who were in the provisional standard and intermediate risk group. Importantly, in the randomized cohort, only intermediate risk patients receive the anthracycline during induction, which will become relevant when we'll discuss our finding. So this is our concept diagram of the entire trial cohort till first randomization. Out of total screen patient, 2516 patients were enrolled in the trial, where 1307 patients were eligible for the first randomization. So from here we can see that 95% of the eligible patients consented for the randomization, demonstrating well excellent acceptance of the trial. So we achieved balanced randomization with 623 patients in each arm. So not only were the number was balanced, but also that all demographic and clinical characteristics for the provisional risk stratification are also balanced between the two randomized groups. Now coming to the first primary outcome, among total 1246 randomized patients, 30 patients died during induction and all were due to sepsis. So we achieved our first primary endpoint as the proportion of the induction death was significantly lower in the short plate group compared to the long plate group, with the absolute risk difference of 2.25%, meaning there were an additional 2.25% induction death in the long plate group compared to the short plate group. The relative risk of induction death was 2.75 times higher in the long plate group compared to the short plate. Coming to the next slide, this is a cumulative incidence plot illustrate the timing of the induction death. The deaths in the long plate group were nearly 3 times higher, significantly higher than the short plate group. Traditionally, in LMIC, it has been believed that children with a newly diagnosed ALL mainly are died during their first or second week of treatment because of their poor clinical condition due to delayed presentation. But what we can clearly see here is that death occurred primarily after the second week of induction and continued even after completion of 5 weeks of induction just before beginning of the next phase, that is the consolidation phase. So this temporal pattern suggests that prolonged steroid exposure rather than initial disease burden may be the key driver for the induction mortality. Next, we stratified the induction death by the risk group and the randomized arm. Induction death were more frequent in the intermediate risk group, particularly in the long played arm. In the standard risk group, overall deaths were fewer, but again, they occurred primarily in the long played arm. This is a cumulative incidence plot stratified by the risk group and the randomized arm, provide additional insights. Among intermediate risk patients, in the long played group, deaths occur particularly after the administration of the second dose of anthracycline. In contrast, in the short played group, death occurred following the second pulse of the prednisolone. For the standard risk patient, deaths were primarily observed in the long played group following the third week of continuous prednisolone treatment. So this pattern suggests that continuous prednisolone is likely the primary driver of the induction death, with the anthracycline potentially adding to the mortality risk in the intermediate risk patient. To identify the risk factor for induction death, we performed multivariable Cox regression analysis and represent the result using the forest plot. This analysis confirmed that both the continuous prednisolone and anthracycline administration during an induction were independently associated with a significantly higher risk of the induction death. Now coming to our second primary endpoint, that is severe non-fatal induction toxicity. The overall frequency of CTCA grade 3 to 4 toxicities were comparable between two randomized groups. Among all toxicities, sepsis emerged as most common, affecting about 1/3 of the patient in both groups. This was followed by treatment-related hypertension, constipation, and diarrhea. Importantly, the frequencies of all individual toxicities was comparable between two randomized groups. To identify the independent risk factor for the severe non-fatal induction toxicity, we performed multivariable portion regression analysis. This analysis revealed that high white blood cell count at presentation and anthracycline used during induction were independently associated with significantly higher incidence of the severe toxicity. Now coming to our secondary endpoints, the proportion of the complete remission rates and the MRD level at end of induction were comparable between two randomized groups. Regarding survival outcome, there were no significant differences were observed between two groups. This demonstrates that shortening prednisolone duration did not compromise the treatment efficacy. So in conclusion, our study demonstrated that a shorter course of prednisolone during induction can significantly reduce treatment-related induction death without compromising the treatment efficacy in young children with non-high risk B-cell precursor ALL. I'd like to acknowledge all the patient and their family who participated in the trial, the entire ICL group for the collaborative effort, our funding bodies, and the NGOs for the support. Thank you.
We have time for one question, if at all. So I don't think there are any more questions. We can go on to the next speaker. So next will be two talks by Dr. Virendra Patil from Hyderabad. One on the experience of management of Ewing sarcoma on interval compressed protocol. The second one is on JMML. Dr. Virendra Patil, over to you. Please keep your talk within 10 minutes. Thank you.
Yeah, just confirm whether it is audible or not and visible or not, please.
Yes, both correct. Please go ahead.
Yeah, thank you. So good evening all. So these are I'll be presenting two abstracts, one from in-house and second one is presented by somebody else. So I'll introduce it later. So to start with the first abstract. Yeah. So it is impact of chemotherapy intervals on outcome in children with localized Ewing sarcoma, real world experience. So which was presented as a poster there. So to set the context here, we know that there are limited drugs which are active in Ewing sarcoma, that is vincristine, cyclophosphamide, anthracycline, doxorubicin, along with ifosfamide, etoposide. So there was a landmark study which was published in 2012 by COG group, which showed that interval compressed chemotherapy is better in terms of event-free survival and overall survival when compared to normal interval, that is 3-weekly chemotherapy. But even after having that study published, so there was so much of hesitation and anticipated because of the anticipated complications in resource-limited settings, whether to continue with dose-dense chemotherapy or to go ahead with the same thing which we had continued before, that's normal interval 3-weekly chemotherapies. So here we have presented our experience on outcomes of both normal interval and dose-dense chemotherapy. It happened that our center Some of the doctors were comfortable in continuing as 3-weekly chemotherapy. They continued to do that. And then some other group shifted to dose-dense chemotherapy from 2016. So we had done the retrospective analysis of all the children in under 18 years who were newly diagnosed with localized living sarcoma between Jan 2016 to December 2025, and their data were collected for these parameters, that is demographic data, chemotherapy schedules, drug doses, local site treatment, complications, and clinical outcomes. So as you know, the chemotherapy is VDC alternated with IE, which were either given 3-weekly or 2-weekly. 3-weekly is called as normal interval, and then 2-weekly was called as dose dense. So the analysis included complications, event-free survival, and overall survival. A total of around 110 patients were noted in this period, but the cohort which was eligible for this study was 74. Who were newly diagnosed at our center and then completed the whole treatment at our center were only 74. So this much data was compared, and it was comparable between the two cohorts, where like a demographic data and a site of distribution of the disease, and also the local treatment schedule, treatment modalities which were used, surgery and radiation therapy, were comparable between the two groups. The things which were distinct were episodes of febrile neutropenia and episodes of admissions for blood transfusions in the two groups, and also the event-free survival and overall survival, which I will discuss in later slides. So this is the slide which shows the results of the whole cohort, showing overall survival at a median follow-up of 36 months, showing 77%, and EFS was 69%, which was comparable with the international references. So when we break down to as per the chemotherapy schedules, we saw that overall survival at 36 months was 87% in 2-weekly chemotherapy cohort, as compared to 69% in 3-weekly chemotherapy, which was statistically significant, and also it was similarly noted in event-free survival, where EFS at 36 months survival was 80% in 2-weekly as compared to 59% noted in 3-weekly chemotherapy schedules. So which was also statistically significant. So the thing which was much more important for us to note was the toxicity rate ratios, which was done by Cox multivariate regression model, which here the flow forest plot showing you statistically significant and very distinct that the episodes of febrile neutropenia and blood transfusions were way different as compared, and it was more in 2-weekly chemotherapy cohort as compared to 3-weekly chemotherapy cohort. But it did not have any impact on chemotherapy schedule or treatment protocol or the mortality. So in conclusion, it was 2-weekly chemotherapy offers superior disease control with acceptable toxicity despite the unique challenges which are well known to our resource limited settings. But 2-weekly chemotherapy is still a feasible and an effective option. This was the conclusion. So directly jumping to the second abstract, the person who is sitting on the chair as a captain is not the person who is sailing this ship. This is and it applies to this abstract. So the second abstract is watch and wait approach in patients with juvenile myelomonocytic leukemia, results of the French national cohort, which was presented by French group by Dr. Nevin, which was actually, I felt very interesting because the number of patients what we see, and then the dilemma what we have when we have these patients with us, whether to transplant, not to transplant, whether to wait and watch, and what to do for them when we have him in our OP. So this is an introducing slide which says that it is included in myeloproliferative neoplasm, and this is the list of diagnostic criteria, which I think is okay for this cohort, audience to be skipped. So as we know that JMML is a genetically driven disease, which results in mutations in the genes, which may be heterozygous or homozygous, which may be somatic or germline, which may be positively driven or negatively driving genes, ultimately leading to hyperactivation of RAS-MAPK pathway, causing clonal proliferation of granulocytic and monocytic lineages. So these are the milestones of treatment options which were presented. Way back in 1997, a landmark study which was published in Blood Journal, which showed two important points: that HSCT is the only curative therapy for JMML, and second important point was that all JMML patients need, HSCT. This was the two important points in way back in 1997. But then came 2007, 2010, where some of the mutations which were noted in these diseases, like NRAS, KRAS, and CBL mutations, and those patients were just followed up and they were doing well, so without any transplant. So then a question was raised whether all patients need transplant in this disease, JMML. So then the other publications which followed that doubt was in 2015, where there were some more additional mutations which were noted to have prognostic impact on those patients, whether they're transplanted or not transplanted, have got some prognostic impact. So it is imperative to look further more than the mutations which were driving this JMML. They are called as aberrant or additional somatic alterations. So with this background, the current guidelines, what it tells how to manage this JMML is that once you have a molecular characterization of the patient, so you have some named and noted mutations. So the mutations which are on the extreme of your left, that is somatic PTPN1 mutation and NF1 mutation, if they have them, they definitely are the candidates for taking up for transplant. And on the extreme right, you can see that if the patient is having CBL germline mutations or somatic mutations, probably those are the patients who can be safely watched and wait. So the question is how to manage the patients who have NRAS and KRAS mutations. Was the one which still not very clear, and it falls in between. And it is noted that if you have any adverse prognostic factors, probably you can consider for taking up for transplant. If not, you can watch and wait. So this study actually answered to some extent what to do with this chunk of patients, where a big cohort of 161 patients were followed from 2000 to 2021, that is 20 years follow-up, which is a retrospective study where patients were the patient's data was analyzed and presented as an abstract. Here they found that about 78% of the patients were taken up for upfront transplant, that is 125 out of 160. Out of them, 9 patients died before transplant, and ultimately 116 patients were transplanted upfront, and 35 patients were kept on watch and wait, modality. And to their, the results showed that 86% of the patients who were managed as watch and wait had long-term survival without HSCT. So this was the conclusion. This was the important point which was noted. Where and the mutations which were found in those cohort were that majority of the patients had heterozygous somatic mutations involving NRAS and CBL, and rest all the patients had homozygous germline mutations in CBL and SH2B3. Apparently, 2 of the patients who had PTPN1 mutation were also included in watch and wait, and they were just followed up without transplant. So out of 33 patients who were on follow-up, 35 patients, two lost to follow-up, and then 33 were followed. Out of 33, only 3 patients had disease progression on follow-up, and ultimately they were transplanted and they were doing good. They are doing good, it seems. And of the 30 patients, they were found to be stable and then presently doing well after 20 years of follow-up. So when they saw that what happened to the disease manifestations, they saw that 50% of the patients after follow-up of 10 years were found to have regression of splenomegaly and improvement in the platelet count, and also the monocyte count were decreasing over the time. When it comes to the mutations actually persisted and it did not fade off. It continued to be the same. It did not have any changes, even whether it is germline CBL mutations or somatic NRAS mutation. The longest follow-up which was noted in the child was at 15 years post diagnosis, that the somatic NRAS mutation persisted in the same way. So these are the some of the genetic the prognostic factors which were found out in the cohort who were followed as watch and wait, where that CBL-driven JMML did not have any statistically significant prognostic factors. But when it comes to NRAS-driven JMML, they found that platelet being less than 45 per thousand, and patients having additional alterations or methylation patterns had poor prognostic factors, and then they probably did bad as compared to other children. So this is the breakdown of that NRAS-driven JMML patients cohort, where favorable profile had age less than 30 months, platelet count more than 45,000, fetal hemoglobin of less than 3% for patients aged more than 12 months, and absence of additional genetic alterations and low methylation profile were the one who did better as compared to other patients. So with all this background, probably the suggested method of approaching a child with JMML after having molecular characterization is this. Once you have a genetic characterization, you can see NRAS, KRAS, and CBL mutation patients can probably followed up and kept on watch and wait strategy without transplant if they do not have additional somatic mutations and also do not have any poor prognostic factors. If they fall on anything, then probably you can consider hematopoietic stem cell transplantation as the better option. And all those patients who come up in NF1 or PTP-NF1 mutation should be taken up for transplant. So in conclusion, they found that, way back in 1997, this was the graph which actually showed HSCT is the only way to go forward. Then here, probably you see that 35 patients who were put on watch and wait actually did better and when compared to the patients who were transplanted. So in conclusion, it says that effective strategy, watch and wait is an effective strategy in about at least 86% of the patients did well, but it needs close clinical and biological monitoring essential for early detection of the progression. And also long-term consequences of clonal hematopoiesis remains unknown, especially the hematological malignancies and autoimmune diseases. And also they were thinking of doing long-term follow-up study into adulthood and also identifying prognostic factors which can guide in a better way to stratify the patients at diagnosis, to put them in watch and wait strategy, notably in KRAS mutated patients because they were very less in this cohort. Thank you very much.
Thank you, sir, for finishing your both. Yeah, thank you for finishing it in time. We may have time for one or two questions. I have a question on the Ewing sarcoma study, sir. Especially when we also use a similar protocol, and what we have observed is that especially post radiation therapy, many of our patients, they will not be able to receive the therapy in 15 days. Sometimes it goes up to 20 days. In our cohort, the median duration for individual protocols, individual chemo was almost 20 days. What is your experience on the adjuvant
So
chemo?
actually we did that analysis, and the median time duration between the chemotherapy schedule in 2-weekly schedule was around 17 plus odd days in our cohort. Yes, I agree that post radiation and as we progress into the course of treatment, their tolerance becomes difficult, and then they land up in complications, especially if they are receiving radiation therapy. Yes, I agree with that, but still taking into consideration, it was around 17.5 to 18.
We may allow one more question. Anyone has any questions?
Thank you very much.
Sir, there is one question on the chat box. Can you please take that?
Yeah, I'll do that.
So the question is, what about how to manage patients who are negative for mutations, Dr. Virendra Patil?
So this cohort actually included all those children who were molecularly characterized. So as we are understanding, probably we need to wait and watch and then see whether they have got any aberrant additional mutations or not. So this study was only to those patients who had mutation analysis, molecularly characterized JMMLs. So we define them by molecular characterization.
Okay, got it. Thank you. So we'll move on to the next talk by Dr. Nidhi. Nidhi will be speaking on maintenance therapy in rhabdomyosarcoma as well as blinatumomab in infant ALL. So over to you, Nidhi. Please try to finish your talk in time. Thank you.
Sure. Thank you, sir. I hope my screen is visible and I'm audible.
Yes, please.
So I'll be presenting two abstracts. The first abstract is this report from the Children's Oncology Group. And the title is, Does Maintenance Chemotherapy Improve Survival Outcome of Patients with Intermediate Risk Rhabdomyosarcoma treated with VAC-VI chemotherapy? So a little background. Intermediate risk RMS by COG risk stratification has a 4-year failure-free survival of around 59 to 73%, with most of the COG studies giving 42 weeks of intensive chemotherapy. Now, this table summarizes the COG studies which have been conducted in the last few decades. The earlier D9803 study used the VAC regimen with a cyclodosing of 2.2 gram per meter square in each cycle, with a cumulative cyclodose of 30.8 gram per meter square. And over the subsequent trials, COG has tried to come down on the dose of cyclophosphamide used. The next trial, which was the ARST 0531 study, was a randomized comparison of VAC 1200 versus VAC VI regimen and showed no difference in outcomes in these two arms. And the recent ARST 1431 trial used the VAC VI regimen with randomization of temsirolimus, and all patients in this particular trial went on to receive 6 months of vinorelbine cyclophosphamide maintenance followed by intensive chemotherapy of 42 weeks. Now, the rationale behind this vinorelbine cyclophosphamide maintenance is the results from this EPSSG RMS 2005 study, which included the high-risk RMS by EPSSG risk stratification, which was similar to the COG intermediate risk arm. And to be precise, almost 76% of the COG intermediate risk actually fall into high-risk or very high-risk arm of the EPSSG. The chemotherapy backbone here was IVA or IVA-DO chemotherapy for 26 weeks. And they showed that in a randomized fashion, that addition of vinorelbine and low-dose cyclophosphamide maintenance led to an improved overall survival at 5 years and post-induction disease-free survival and overall survival at 10 years. So the COG then attempted to see the efficacy of this maintenance on their VAC-VI backbone. But since all patients on the ARST 1431 trial received this maintenance, the comparator arm was chosen as the VAC-VI arm of the previous study, the ARST 0531. So the primary objective of the study was to compare the event-free survival and overall survival of patients with intermediate risk RMS treated with the VAC-VI arm with vinorelbine cyclophosphamide maintenance on the ARST 1431 trial to those treated with the VAC-VI backbone on the ARST 0531 trial. The secondary objective was to compare these patients with the VAC 1200 outcomes of these patients with the VAC 1200 arm on the ARST 0531 and the VAC 2200 arm of the D903 trial, 9803 trial. So patients who fall into the intermediate risk of the ARST 1431 in all the three trials were included in the study, and any patient who was falling into low risk and high risk by this stratification in the previous trials were excluded, since the risk stratification evolved over the serial trials. So the patients who were included were ERMS with stage 2, 3 and group 3, and ARMS stage 1 to 3 and group 1 to 3. So a total of 149 patients were treated with the VAC-VI with Veno CPO maintenance on the ARST 1431 trial, of whom, based on the histology, stage, and IRS group, 105 were eligible for analysis. Coming to the VAC-VI arm of the ARST 0531 trial, 226 patients received this chemotherapy and all were eligible for analysis according to the set criteria. So on comparing the outcomes of VAC-VI with maintenance, in the ARST 1431 trial with the VAC-VI only chemotherapy on ARST 0531, there was no difference in the 4-year event-free survival and 4-year overall survival. When the outcomes were compared with the VAC 1200 arm of the ARST 0531, which entailed a higher cyclophosphamide cumulative dose, there was no difference in the 4-year event-free survival and overall survival. And when this was compared with the VAC 2200 arm of the D9803 trial, again, no difference in the 4-year event-free survival and overall survival. So this table sort of summarizes the results of this study. And as we can see, across the various trials with varying cyclophosphamide cumulative dose, the 4-year event-free survival continues to hover between 59% and to 69%, with the overall survival of 72% to 76% in the various COG studies. Now, I've also included the EPSSG RMS 2005 trial, which with the Veno CPO maintenance arm in this table. So these patients received a cumulative cyclodose of 17.3 gram per meter square, which was higher than that in the COG VAC-VI with Veno CPO, where the cumulative cyclodose was 12.6 gram per meter square. But if we see in terms of outcomes, the 4-year event-free survival reported in this study was 77.6% with a 4-year overall survival of 86.5%. Which is probably one of the highest survivals reported in this subgroup. And this was significantly better than the arm which did not receive the Veno CPO maintenance. So this could also be due to prolongation of chemotherapy duration in the EPSSG backbone with the Veno CPO arm, which was initially 26 weeks, and with the maintenance it became around 52 to 53 weeks. Coming to the strengths and limitations of the study. So the strength of the study was this is an intention to treat analysis, and it included a group of prospectively treated patients. And the limitations were, again, it was a non-randomized comparison. There was imbalance between arms with more T2 and parameningeal tumors in the ARST 0531 study and more patients undergoing DP in the delayed primary excision in the ARST 1431 study. Though both the arms were, though the results were adjusted for these differences. And of course, these studies being conducted over different treatment periods also made the comparison a little difficult. So they concluded that the 4-year event-free survival and overall survival of intermediate risk RMS patients treated with VAC-VI chemotherapy and 6 months of Veno CPO maintenance was not statistically different compared to those treated with the VAC-VI without maintenance. So probably this maintenance was not relevant for the COG backbone, which now they are reviewing in a prospective randomized manner. Coming to the second abstract. So this is from the Princess Maxima Center, and this is titled as Sustained Effect of blinatumomab in KMT2A rearranged infant acute lymphoblastic leukemia, long-term outcomes, key safety parameters, and pharmacokinetics. So a little background. Infant ALL comprises of less than 5% of all childhood ALL, with 75 to 80% being KMT2A rearranged. The long-term survival for older children with ALL continues to be more than 90%, but then the survival in infant ALL is dismal still despite treatment intensification. And most of these relapses in infant ALL are early relapses. Blinatumomab is a safe and efficacious treatment for adults and children, older children with relapsed refractory ALL after intensive chemotherapy, and hence has a potential role in KMT2A rearranged infant ALL. So this was a phase 2 single-arm multi-center interventional study where 30 patients with infantile ALL, which was KMT2A rearranged, were enrolled, and all patients received one additional cycle of blinatumomab on the interferon 06 backbone at a dose of 15 microgram per meter square per day as a 28-day infusion. And this cycle of blina was added immediately post-induction since most of the relapses were early. So they tried to incorporate the cycle early in the treatment. Now, the early outcomes and severe toxicities and MRD clearance kinetics of this particular protocol were published in NEJM in 2023. And the current abstract included long-term disease-free survival and overall survival, the toxicity and key safety parameters, including infection, rate of infection, use of IVIG and GCSF, and pharmacokinetics in the form of steady-state clearance and steady-state concentration and clearance of blina. So coming to the outcomes, at a median follow-up of 4.2 years, this study showed excellent overall survival and disease-free survival in the KMT2A rearranged infant ALL, with a 4-year DFS of 83% and the 4-year OS being 93%. And if we see all the events occurred early, that is up to 2 years, and no late relapses were noted. When they compared the outcomes with the historical interferon 06 cohort, there was a significant improvement in outcomes compared to the interferon 06 trial, with 4-year DFS being 44% in the interferon 06 compared to 83% in the current study. Again, significant improvement in overall survival compared to the interferon 06. Coming to the toxicity and key safety parameters, so the rate of any infection per patient post-induction was 87%, with 70% patients having grade 3 or more infections. But interesting point is that no infection-related deaths were noted post-induction in this cohort, while the Interfan 06 reported 4% post-induction deaths. Two-thirds patients received IVIG supplementation, most of which was given during the Blina arm. Now, if we see the phase-wise infection incidence, it was least during the Blina phase. And then subsequently, if we see, the most common infections were upper respiratory infections and urinary tract infections. Coming to the pharmacokinetics, so they also measured the steady state concentration of Blina and median clearance and compared it with other age groups. And they found that the median clearance of Blina did not differ across various age groups, and hence the dose which was given in this study was appropriate. So coming to the limitations, this was a non-randomized study because it's a small group of patients, and plus already unsatisfactory outcomes have been reported in this subgroup of patients in the Interfan 06. Again, direct comparison of infectious disease with historical control was not done, as the definitions for severe adverse effect was different across the two trials. But of course, this study gave future directions for the ongoing studies, and both the Interfan 21 and the Children's Oncology Group ongoing study, that is the ALL 2321, both have incorporated blinatumomab upfront in the chemotherapy backbone. So to conclude, this study proves the sustained efficacy of Blina with no late effects and a significant improvement in survival in KMT2A rearranged infant ALL. There were no infection-related death when Blina was added to the Interfan 06 backbone, and there's no need for dose adjustment of Blina in infants when compared to dose in older children. Thank you.
Thank you, Dr. Nidhi. We have time for one or two questions. I guess there are no questions. My question to you, Dr. Nidhi, is that why there is so conflicting results? On one continent, it's showing the maintenance therapy is showing so much benefit. From the North America, it is not showing any benefit.
Yeah, I think it's more than maintenance, no maintenance. What I feel after reading the two papers is it's more of the duration of chemotherapy, because that's the only thing which is coming out to be different. So the EPSSG gave 26 weeks of intensive chemotherapy, while the COG was already giving 42 to 42 weeks of intensive chemotherapy. So probably prolonging the duration of chemotherapy of chemotherapy, any form of chemotherapy with maintenance in the EPSSG protocol led to improvement in outcomes.
Yeah, thank you, ma'am. So thanks, Dr. Nidhi. So we now invite Dr. Richa Jain for one more talk on blinatumomab administration in infant ALL in ALL therapy. So over to you, Dr. Richa, ma'am.
Hi. Am I audible?
Yes, ma'am. Please go ahead.
Right. Let me just make it screen. Right. So this was a pre-paper session that I presented at SIOP, adapting ambulatory administration of blinatumomab in relapsed refractory B-cell ALL. And we all, Nidhi has just talked about Blin. I think we all use or want to use blinatumomab in our ALL patient. Suffice it to say that over the last 10 years from December 2014, when it was initially approved for adults with Ph-negative relapsed refractory B-cell ALL, multiple accelerated approvals have been obtained for blinatumomab, and currently it has been granted full approval in all ages for MRD-positive B-cell ALL and all relapsed refractory ALL, and it is being given for infant ALL as well as upfront, intermediate, and high-risk ALLs. So, however, it is not freely available to us in India. one full month of hospital admission costs, which are about 3,000 to 1 lakh in a government hospital like ours. And in a private hospital, they can range anything between 2 lakhs to 4 lakhs or even more at times. In comparison, when we see that the cost of a normal just chemotherapy-based treatment for ALL at a government hospital, it barely costs 3 lakh to 4 lakh at centers like ours. So the cost discrepancy is immense. This was a study that we had done over, this was a retrospective data analysis over 5 years. We have been giving blinatumomab since July 2020 in the middle of COVID. And we primarily use at this point for relapsed refractory pre-ALL, and we have recently started using it for infant ALLs. We use a backbone of UKLL R3 protocol for our relapsed patients. And in this study, we had a total number of 18 patients who were given blinatumomab, and a total number of 22 cycles were given to these patients. 14 patients received a single cycle and 4 patients received 2 cycles each. The median age of these patients was 8.3 years with a range between 5 to 12 years. And the diagnosis was late relapses in 6, early or very early, that is high risk relapses in 11, and refractory disease in a single patient. All the patients had medullary relapse. In addition, 8 patients had extramedullary relapse as well. We noted adverse effects in 1/3 of blinatumomab cycles, 8 out of 22 cycles, which I'll be just talking about in a bit, and 5 of 18 of these patients had relapses. What were the adverse effects that we noted? We saw cytokine release syndrome, which 5 episodes of these in about 22 cycles that we gave. A single child had 2 episodes of grade 3 cytokine release syndrome requiring tocilizumab in both the episodes. And in the final episode, that was the second time we were administering blinatumomab, we had to abort the blinatumomab prematurely. All these cytokine release syndromes occurred within 3 days of starting blinatumomab. And neurotoxicity occurred in a single child in this cohort with seizures, single episode, which were easily controlled on levetiracetam, and eventually we could complete the blinatumomab. Febrile neutropenia occurred in 2 children, of which 1 child had culture-positive febrile neutropenia. As far as the outcome is concerned, remission was attained in 94%, that is 17 of these 18 patients with MRD less than 0.01 10 to the power minus 4. And 12 out of these 18 patients underwent hematopoietic stem cell transplant, while 6 were continued on chemotherapy. At this point in time, 14 of the patients remain in remission at a mean of 20 months, which includes 6 who are currently on chemotherapy. We have had 2 treatment-related mortalities, both for post-transplant, and 2 patients relapse, including 1 post-transplant. So we started ambulatory blinatumomab because we are a 2,000-bedded government hospital with 300-bedded pediatric center. We have barely 15 beds. However, we see a burden of oncology, 500 new patients annually, and hematology of 300 to 400 new patients annually. Every year, we have more than 100 new ALL, including 25 relapsed ALL. So it's a huge burden and very busy OPDs and wards, as we all in large hospitals see. We have extreme paucity of beds with the average waiting time for admission to inpatient chemotherapy of 3 to 6 days. Average number of patients awaiting admission to PHO ward at any point of time are 5 to 8 in numbers. There are a lot of so-called inpatient chemotherapy regimens which are being administered on the outpatient basis after modification or adaptation, and these includes VAC, VDC, and as well as IE for slightly older children. For very young children less than 6-7 years of age, we prefer to give IE in admission. Rapid Kojak is entirely given on outpatient basis after making some modifications and giving fluid throughout 12 hours. And cisplatin for hepatoblastoma is also frequently given on the outpatient basis. Febrile neutropenia is majority of the patients are managed on ambulatory basis with only high risk or complicated patients who require some kind of intervention. They are admitted. So with this kind of a background, including the fact that the cost of inpatient stay is very high, though it's extremely subsidized in a government hospital, still for an individual or a private room, for a patient, it would cost 1 lakh rupees over a period of 1 month. So that if we compare that to the median monthly Indian household income, that is barely 12,000 rupees. And the similar median monthly household income is seen in the patients in our unit, which is 15,000 rupees. So this kind of 1,000 rupee of cost for private room of 28 days is also immense for the patient. So we gave the initial 10 patients 10 cycles of blinatumomab during the COVID period entirely as inpatients. And we found that the side effects were manageable and we got used to giving blinatumomab. However, because of the increasing logistic concerns and increased drug availability, it led us to initiation of ambulatory blinatumomab. What are the steps to shifting to outpatient care? We assess the family, we look at our logistic support, and we ensure monitoring on outpatient basis. The time our patients spend as inpatient for cycle 1, a minimum of 7 days of admission, a dose hike from 5 to 15 microgram in a couple of days at 15 microgram if they are doing well, then we are comfortable in discharging them at this point. For cycle 2, since they have already had an uneventful cycle 1, we are comfortable in discharging them earlier between 3 to 5 days. We assess the family, the patients and the caregivers should have a good understanding and should be motivated after repeated counseling by multiple people, including faculty, our DM residents, nurses, and social worker. They should understand the infusion pump functioning. They should be confident about being on the outpatient basis, and they should know when and where to report in case of a problem. So people who classify for transition to outpatient administration, they have to have a local stay within 15 minutes travel to the hospital and a transportation of their own. An uninterrupted power supply should also be ensured. So we use an inverter, or we basically ask the patient to buy an inverter if they don't have inverter as a backup. But we also ensure that the infusion pump we are giving them has a battery backup of at least 3 to 4 hours. The infusion pump is provided by us, and the bag change happens every 24 to 48 hourly. Patients visit the PHO ward at a fixed time, and the blinatumomab is reconstituted in the laminar flow unit by one of our residents or oncology nurses. The doctor assesses him on a regular basis every 24 hourly, well-being, vitals, complications. We attach the bag and check the infusion pump, and we fill up our adverse event sheet, and the subsequent plan is noted, and the child is sent back home. This is blinatumomab being reconstituted in our laminar flow unit. The helpline number is provided after the infusion pump is given by the hospital. A daily phone call occurs, and alternative physical assessment is done, and line dressing is done every 7th day. Once a week, oncology clinic visit happens for consultant assessment, and blood works are done twice a week for the initial 15 days, followed by once a week. So what are the challenges that we face? The distance to travel is a big barrier because 90% of our patients reside in distant places where the median distance traveled is 153 kilometers. So only 10% of our patients reside within or close to the city, and they can stay at their own homes. So we have ensured homes away from home with the help of various of our NGOs, including Can Kids and Access Life, which provide home away from home along with a 24-hour vehicle and electricity. What are the adverse effects we have noted? While patients are on ambulatory therapy, there have been no episodes of cytokine release syndrome after discharge. 2 episodes of febrile neutropenia were noted on day 20 and day 23, and both required admission for parenteral antibiotics and cessation of blinatumomab at this point of time, including one patient who had central line related bloodstream infection and needed the central line removal. No patient has had an unplanned visit till date. So as of now, touchwood, we have been lucky to have no major line or pump related issue with any infusion interruption or pump failure. However, like this, one of our smallest child who was getting blinatumomab got just pulled out a central line at 2 a.m., at which time we had to establish a peripheral venous access, and blinatumomab was restarted through a peripheral cannula, as we can see in her left arm, and a new central line was established in the morning. We decided not to discharge this child prematurely. So, however, for our patients, the ambulatory therapy is a boon as they are able to carry out activities of daily life, interact with other children, and are away from the morbidity of prolonged admission with risk of hospital-acquired sepsis, emotional and mental stress, and have a significantly better quality of life. The economic benefits are for both us as well as the patient because of freeing up of patient bed. We have an average bed days per year available to us of 5,475 as we have 15 beds over 365 days. With the initiation of ambulatory blinatumomab, we have been able to free up in the last year 252 bed days or 5% of our available bed days. because of 12 ambulatory cycles of blinatumomab, with per patient admission day reduced from 56 to less than 15 days, which improves our capacity to administer blinatumomab to more patients. And we have now started giving it to infant ALLs as it has become available and to refractory ALLs as well. So just to note data from world over, ambulatory blinatumomab data has been published from Mexico, where 7 patients were given blinatumomab on OPD basis. They gave only abbreviated cycle of 21 days, and they noted no significant adverse events except for grade 1 CRS in 2. COG has published data from 150 institutions who have administered blinatumomab. So majority of the institutions have done ambulatory, 91% have done ambulatory administration, with 9% only admitting patients throughout 28-day cycle. So the world has moved away from inpatient to ambulatory blinatumomab, and majority of the ambulatory patients have a hospital stay of less than a week. However, home health agencies are available for 34% of the cases for patient support and monitoring, which are not available to us. So in the end, I would like to acknowledge all the patients, their families who are a part of this work, the NGOs that support us, blinatumomab Humanitarian Access Program, which provided blinatumomab to 6 of these 18 patients, and the Pediatric Hematology Oncology Unit. Thank you.
Thank you, ma'am, for showcasing the work on how to deliver this novel therapeutic drug delivery system in a resource-limited setting. Very interesting and exciting. So we may have one question, if at all.
Right.
One question is that which any particular infusion pump was used, any particular brand? So
I have that noted somewhere, and I'll have to check it. I think some of my DM residents may answer in the chat box, because they remember, we remember checking on the exact brands which provide that 3 to 4 hour battery backup. So if any of them is here, or I'll try to find out and put it in the group before the end of the session.
No worries. Yeah, sure. So we invite the next speaker, Dr. Siddhartha Lashkar sir from Tata Hospital, Mumbai, to give us the updates on radiotherapy in pediatric malignancies. So Dr. Lashkar sir, are you there, sir?
Yes, Anand, I'm there.
Yes, sir. Please, over to you, sir.
Thank you very much. Good evening, everyone. Thanks, Manas, for the invitation. I was happy when you told me that I could present later in the evening because I was busy with something, but I still seem to be in the car. But yes, let me see if I can share my slide. You can see my slide?
Yes, sir. Please go ahead.
Okay. Thank you very much. And I'll keep my presentation very short. And so there were quite a few presentations during the radiotherapy session and the prose sessions. And a lot of it were related to techniques of delineation of tumor volumes and target volumes, which were very technical. But I chose the 2 abstracts, which I thought would be of interest for surgeons, medical oncologists, and radiation oncologists. And this is to deal with a very common question that we keep addressing in our joint clinics. And this is to do with the role of post-op adjuvant radiotherapy in Ewing sarcomas. Now, the first abstract that I chose, and both these abstracts are actually related, trying to answer the same question. And the first abstract trying to answer the question using something called a causal machine learning algorithm. And the second is a more clinical decision-making process. And we'll compare and see how the outcomes differ between the 2 different ways of defining the indication of radiation therapy. The first one is called, the title is Personalizing Adjuvant Radiotherapy in Localized Ewing Sarcoma, Causal Machine Learning Analysis. And this came from a very famous group from Germany, from Essen, the group of Uta Dirksen. This was presented by Philip Hessen. And the main thing was to be able to identify distinct subgroups of patients who could be predicted to benefit from adjuvant radiotherapy using causal machine learning. And this was a relatively large, actually, probably the largest database of post-operative radiotherapy. It had 1,500 patients included in the analysis from the EuroEving 2008 to the EuroEving 99 trials. And what they really looked at is how well could the machine learning and this analytic came
Anand, did we lose Dr. Laskar? I can't hear his voice.
I think he's traveling, so maybe we lost him.
Yeah, must be the network issue over there. I think Anand, the next speaker is Dr. Ramandeep Arora.
Yes,
So
sir.
if we are not able to connect with Dr. Laskar, maybe Raman can start his presentation. Oh, there you go. I can see Dr. Laskar now.
You're on mute. You have to unmute yourself.
Dr. Laskar, we can't hear you. Raman, maybe I think you can start your presentation. I don't think we are able to connect with Dr. Laskar.
Okay. You want to start now?
Yes, please. Yes, please.
I hope you can see my screen.
Yes, we can. We can, and we can hear you.
Okay, so thank you for staying till the end. And I'll take 5 to 10 minutes to talk about a couple of presentations given by Dr. Roberta Ortiz, who some of you may know, who's a pediatric oncologist from Nicaragua. But more importantly, she's currently the medical officer in WHO on childhood cancer. And so she's our main link over there. And she gave a couple of talks in SIOP. One was an update on WHO GICC, and the other is some new exciting activity which is being done on generating country survival estimates, which are expected to be released on the ICCD in next month. So we look forward to that. And she also very kindly shared her slides to me. So, that made my life very easy. So the WHO GICC had a resolution with the World Health Assembly in 2017. The launch was 2018. The technical package came out 2021. And very recently, some of you might have seen the United Nations General Assembly took out a statement, a political declaration at the fourth high-level meeting, in which there is a small paragraph of 3 sentences, which says childhood cancer. And I think that's the first time such a declaration has had it. And so that from a policy point of view, advocacy point of view, is a huge landmark achievement for the global community. So today in the WHO GICC, and this dashboard is courtesy the St. Jude's Global Alliance WHO collaboration, 85 countries are engaging in some way or form with this. 53 focus countries in dark blue have signed MOUs. The governments have signed MOUs with WHO. And so you will see almost all of Central and South America has been covered, while many others are engaging in some way. So India is engaging in some way through its institutions, but there's no formal commitment with the government. So this has been the progress, and you have all again seen this, the plan, the framework for achieving this, which is the cure-all framework. And I'm putting this up because the progress is in the dimensions of C, U, R, and E. And I'll take one slide each. So C is center of excellence. And over here are two examples, one in South America and the other in Myanmar, which is more close to us. So in the Myanmar area, as you will see from the map over there, there are two main centers in Mandalay and Yangon, and the number of satellite centers have been created or have been partnered with. So a network has been created. In South America, it's inter-country network, which is what the whole PAHO group is doing. So this is one example of how centers of excellence are being created within the Southeast Asia region right now. As I showed in this slide, you can see Nepal, Bangladesh, Myanmar, and Sri Lanka and Bhutan have actually signed MOUs, and Pakistan. So actually India is the only main country left which hasn't signed an MOU with the WHO on this. The second part is U, which is universal health coverage, which is so important. And again, several activities are ongoing over here. One is to have a national childhood cancer plan. So the pie chart on the right shows, what kind of national childhood cancer plans are existing in the world. As a result of participation over in WGICC, as you will see in the bottom, 6 countries, Ghana, Kenya, Zimbabwe, Morocco, Nepal, etc., now have these national childhood cancer plans. Moreover, they're also looking at which countries have incorporated benefit packages, financial benefit packages in their plan. And again, you can see a list of countries, El Salvador, Peru, etc. So this is all work going on at the policy and the finance level. Coming to the third element, which is R. So R is regimens for management. This is what happens in our hospitals day in and day out. How do we deliver comprehensive management? And one of the flagship programs has been the GPA-CCM, which is the global platform for accessing childhood cancer medicines. There's a lot of effort and resources which have gone into it. The map over here will tell you the countries which joined in 2024. So again, Nepal was the first country inside. In the next phase, Sri Lanka is going to be the country. So in the first phase, they have benefited 1,000 children by providing them 331,000 plus medicines in 26 hospitals in 6 countries. So a lot of effort, logistics, funding, which is going on. Finally, coming to evaluation and monitoring. And there are a few extra slides over here because this is also a second part of a presentation. And for me, a very interesting area. It is also related to what Venkat told in his first presentation. That is, how do you monitor what's going on? So as part of monitoring, they are developing certain metrics. And so the book which you see on the right-hand side is a WHO book which is coming out in the next few months, which is looking at metrics not just for childhood cancer, but for breast, cervical, and all cancer. They have finally, after 3 rounds of Delphi, come to 22 essential metrics and 26 optional metrics. So 48 in total. And that will be coming out soon. Now, along with defining the metrics as to what, how you measure progress, there is the whole part about, well, what do we know about the world? So this slide is from the Concord 3, which looks at survival data at registry level. And as you will see, dark orange is where you have national coverage, light orange where you have regional coverage, and a lot of the world is in gray and white. But if you zoom in into this, you will see 2 pockets of India. So you see Guwahati, there's a registry there which has contributed to Concord 3. And in Kerala, Karunagapalli, if I got the pronunciation right, has also contributed data. But these are small number of patients, not a lot of patients, and they have provided data only on leukemia and CNS tumors. But this is where we exist today. So as a result of that, the Lancet Oncology Commission did this estimate. So India stands between 25 to 50% range of survival. So now to plug this gap, the WHO is working with each country to produce a global status report by identifying survival of 0 to 14 and 0 to 15 to 19-year children in the years 2017 to 2021. And they will start with ALL. This is a project which is going on, and this report is supposedly going to be released on 15th of February. So we wait to see if that happens. And so what they're doing is they reach to each ministry, they get their buy-in, and then through consultation, they have a country portal open only to the ministry, and then the data is fed in, and that's what's produced. So what's happened so far is this slide is from November, so at October when SIOP was done. So at that time, as you can see, so many countries had joined, but not every country had joined. Coming specifically to Southeast Asia, out of the 9 countries, 5 had logged in and 2 had actually shared some data. So that's where we are. And so that brings me to my last slide, which is the WHO's efforts to monitor and evaluate, which is the alphabet E in the cure-all framework. With that, I thank you for your time and for staying back this long. Thank you.
Raman, excellent presentation. May I ask one question?
Yes, please. So please go ahead.
Yeah. So Raman, I mean, you have presented the whole data and this thing. Just would like to know what's the way forward for India, and what are the 3 things you would like to do in next 1 year to put India on the map?
So the way forward is, one is that all stakeholders, PHU, IAP, INFOG, NGOs, etc., are doing their own job, Tata Memorial Hospital, WHO, and so on. So they are continuing to do their own things. And that's happening at multiple levels. So WHO CR Childhood Cancer Network is there. Many hospitals are part of it. Indian Childhood Cancer Initiative is another effort going on. And that's going on. ICMR and government are also doing their things. So all those things are going on. Within ICCI, one of our key targets has been to engage with the government, which has happened. And we had met the Minister of State of Health and Family Welfare, thanks to you, actually, my personal thanks to you. And this happened, I think, in October or November. And we had made a submission to him and asked him for 3 things. The first one was creation of a technical expert group for childhood cancer, because that's how the plan is developed. I'm very pleased to say, because we haven't announced it formally yet through any social media, but very pleased to say that on the 9th of January, the ministry created the first technical expert group on childhood cancer, and it has got around 17 or 18 people on it. The next step is going to be to have the first meeting of the TEG, which we are proposing to them can happen in February. So the idea is that TEG is, which is full of our colleagues, is going to work with the government to give shape to the plan recommendations, as well as all the work which is going on provides valuable data for the government to use, whether it's in cost effectiveness or access or mapping or standards, etc. So for example, the PHU IAP NTPPO manual is something which you would present to the government and say, here is PHU IAP, which has been training for so many decades. It could be used and endorsed by the government as an official manual for the country. That would be one example of using an existing resource. So that's our plan. Our plan is to bring the government on board, to work with them on the TEG, to get them to commit to a national childhood cancer plan, which I think will take 2 more years.
Great. Thank you so much. Manas, anything from your side?
Nothing, Shweta. Thank you so much. And I think, we brought SIOP back home, so that's great. We wanted to host SIOP in India, but I think there's still time for us to do that. But at least we could all meet and discuss the best of SIOP. And I will just ask you to give the last comments.
Thanks, Manas. I think it was a wonderful effort from all of you. And the presentations were great. The speakers were great. And when I was listening to all these presentations, I had a mix of emotions. One is that, like, how much I missed by not attending SIOP. But second emotion was there. Thank God we are having a best of SIOP over here and we are able to catch up. So I think with this emotions and with this hope that maybe we'll get the best of SIOP, maybe in person next year, and we'll try to have more interactions and more learnings from the world, how they are doing, and what best we can bring to India to improve our childhood cancer care. Thank you so much, and I think we can end the meeting.
Yeah, thank you so much. It's right on time, so thanks a lot.
Thank you.
Thank you.